Good evening, everyone, dear all. On behalf of the Indian College of Hematology, the academic wing of Indian Society of Hematology and Blood Transfusion, I welcome you for the live meeting on advances in biomarker testing in chronic lymphocytic leukemia. With no further delay, I would like to invite Program Director for today's meeting, Dr. Avinash Popali, sir, Hemato-oncologist, CIIHO Nagpur. Over to you, sir.
Thank you, Praveen. At the outset, I must welcome you all for this important meeting, which is fairly interesting and which is going to be actually spoken lectures as well as panel discussion by the eminent hematologists of our country. Let me first introduce what is Indian College of Hematology, which might be something bit new for some people. It is basically an academic wing of Indian Society of Hematology and Blood Transfusion. This society, college was proposed because almost all the societies in India have got their own colleges, which are part of the academic part of the society. So Indian College of Hematology was proposed way back in 2017, and it was ratified in 2019 annual national meeting. And in 2020, it actually started taking over the function of conducting educational programs. So the number of educational programs are in the initial phases of conduction. This is today's is the 5th program of Indian College of Hematology, and we want to expand this further and further. And we want to take it to the all levels of the society, to society of doctors, as well as to all parts of the country. So as one of the steps towards that, today's program is earmarked for chronic lymphatic leukemia, and this particular program will deal with advances in the biomarker testing in chronic lymphatic leukemia, for which we have got an international speaker who is a technical expert in the diagnosis of the various molecular tests which are being done, particularly the immunoglobulin heavy chain variable region testing, which is important biomarker in the CLL treatment, as well as the initial the predictive marker, you can say so. So this particular disease is a very common disease, we all know, as it is the commonest leukemia in the Western world, and it is also very, very common in our country too. And it has got definitely a variable biological period or course, but still definitely with the help of various biomarkers, you can actually predict and prognosticate this disease, and accordingly you can definitely prognosticate in the sense that how the patient is going to behave. At the same time, you can select drugs which you will use while dealing with these patients who are coming to you for the management. We all know that most of our patients of CLL do not need treatment in the upfront setting, but there are certain criteria which we all know and which might discuss, whereby we are going to actually decide which patients will need treatment. And once we decide treatment to be given, then the role of all these biomarkers come in to select, or you can say an algorithm for selection of initial treatment of CLL patients is based on this biomarker. And then definitely when the patient relapses, you have to go for second line therapy, and then again it relapses, consumes the BTK inhibitors as well as BCL2 inhibitors, you think of PI3 So all this journey of management of the patient is based on the biomarkers, and therefore I believe that this is an important activity we are conducting today, and I am happy that we will now shift our focus on the actual event. And the first lecture, I would like to invite Dr. Sanyal, who is a consultant hemato-oncologist at Fortis Hospital, Mumbai, and the topic which we are which he will be dealing and speaking to us would be the CLL risk stratification and particularly treatment of the high risk disease. Dr. Sanyal, please.
Yeah. Thank you, Dr. Popali, for the kind introduction. Just give me a minute to just arrange the full stuff. So I'll be talking very briefly about the risk stratification of the CLL and the treatment of the high risk disease. So CLL is basically a disease which is characterized by the clonal proliferation of the B lymphocytes. And you can see this two peripheral smear, which is a normal one. And you can see in the right side of the screen, there is a lot of lymphocytes seen. So there is lymphocytosis, one of the very important features of the peripheral smear of the CLL. And the characteristics of this particular type of cell is called smudge cell. What is this smart cell? So it is basically these cells are very fragile. So when you do the smearing, these cells become damaged, and these damaged lymphocytes in the site preparation actually called the smart cells, which is one of the important characteristics of the CLL peripheral blood smear. And you know, the most of the time the CLL is an incidental diagnosis. So the people who are the pathologists who are the reviewing the slides, even in the health checkup or something, some other indications, they has to pick up this lymphocytosis and the smart cells and inform the respective hematologists that for the further workup. So this thing is extremely important. So what are the risk factors for the CLL? So some possible risk factors for the CLL have emerged. So CLL is almost twice as common in the men that women, with a sex ratio of 1.5 to 2. Incidence of CLL is believed to be higher in the Caucasian than in the other racial group. Less common in Asian population, especially is the Chinese and Japanese population. But we Indians are not the Chinese or Japanese population. So Asian population means here is the Chinese and Japanese population. CLL has some familial orientation. So family history of the CLL and other lymphoproliferative disorder may be a risk factor. And 5 to 10% of the patient of the CLL report a family history of malignancy and the lymphoproliferative disorder. So in the left side of the table, you can see there are a lot of markers, which are actually the prognostic biomarkers. And right side of the table, you can see some of the markers which we actually practice in our clinic very commonly. So if I go to the left side of the table, there are particularly the blood markers like a beta-2 microglobulin, lactic dehydrogenase, LDH, that we do on the baseline. Lymphocyte doubling time is an important thing, which is an indication of the treating the CLL. So if the LDT is less than 6 months, then patient needs treatment. These are the immunophenotyping parameters that we actually needs to diagnose CLL by the immunophenotyping. IGHV mutation status, mutated, unmuted. There are a few chromosomal aberrations, genetic mutation, and non-coding RNA and other stuff that I mentioned here. So if I took a little bit about the few of the things, the most important comes about the deletion 17p as a TP53 mutation, which actually predicts poor response to chemoimmunotherapy. Notch1 mutation, we generally don't do in our routine practice, predicts poor response to the anti-CD20 therapy, particularly rituximab. CD49D is a bad prognostic marker. So it inhibits cell trafficking in the setting of novel FCR target therapy. IGHV mutation status. So unmutated is bad and mutation is a good. And a complex cytogenetics predicts poor response to chemoimmunotherapy when the complex karyotype with a major structural abnormality is there. And a microRNA associated with a chemotherapy refractory disease. MIR155 predicts the therapy response. So overview of the genetic complexity of the CLL. So genetic aberration identified in the CLL include genomic abnormalities and specific genetic mutations. So combination of these aberrations along with the immunoglobulin heavy variable mutational status result in biological and clinical subgroup associated with a varying outcome. So few of the genetic abnormalities and the genetic mutations we actually combine, and you can see that how is the frequency the untreated patients you can get. Time to first treatment, but Dr. Pompali very nicely pointed out that all CLL, whenever they diagnose, they don't require any treatment, and a progression-free survival and overall survival. So if I come to few very important prognostic markers, particularly comes in the deletion in 13q, which appears to be the good prognosis. Trisomy 12, believed to be intermediate prognosis. Deletion 11q and deletion 17p believed to be the bad prognosis. Deletion 14q is a good prognosis. Recurrent balance translocations are appear to be the rare, but they are a bad prognosis. So if I go by the incidence wise, you can find that bad one like a deletion 11q and deletion 17p is around. Deletion 11q is actually more common, 10 to 25%, and deletion 17p is around 5 to 10%. The good one, like a deletion 13q, you can get 50 to 60% cases. We generally don't do in our practice in a notch1 mutation, but it also has a 6 to 12%, and which believed to be a advanced prognostic marker. So what are the criteria for diagnosis of the CLL? How we diagnose CLL? So basically the two investigations, which is really very helpful. One good complete blood count and immunophenotyping of the peripheral smear, the peripheral blood. So that very clear cut tell you whether you are dealing with a CLL or not. So when we got a diagnosis of the CLL, few things are very important, like a history, whether it's incidental or whether patient has any B symptoms like night sweats, fever, loss of weight, or constitutional symptoms, whether patient has any lymphadenopathy, whether patients are organomegaly. So history and the physical examination is extremely important. Performance status, equally very important. And some serum chemistry, like particularly the basic biochemistry, serum immunoglobulin level, because CLL is an immunosuppressed disease, and a direct Coombs test, which you generally do at the baseline. We generally don't do marrow aspiration and biopsy during diagnosis, but if the patient is having a significant cytopenia, then to understand the cause of the cytopenia, because we know that CLL causes pure red cell aplasia, CLL causes ITP, CLL causes some autoimmune manifestations, and that can cause cytopenia. So to understand all these things, if there is a documented cytopenia, so then definitely the marrow aspiration biopsy helps us to understand that. Imaging, I generally in my practice, though if you go by the Rice staging or Binet staging, they are all the lymphadenopathy and the hepatosplenomegaly mentioned as a clinical exam part, but I generally do one simple neck, chest, abdomen, pelvis with contrast, just to understand that whether there is any bulky adenopathy somewhere in the abdomen or chest, or some whatever the lymph node basic sizes are there, to get a baseline idea that how the things will be in the coming days. Baseline FISH important. So all the patients, again, I'm telling you repeatedly that does not require any treatment, but baseline FISH is very important. So what we do in our practice commonly, we do a baseline FISH. We do a TP53 mutation separately and IGHV mutational status. IGHV mutational status don't change. So if you do one at a time, you are done. But FISH studies, because CLL is a heterogeneous disease, and the FISH abnormality can be changing over times. So if you are not treating the CLL, baseline FISH is important. But when you are going to treat, say, after 3 years, 4 years, 5 years, 7 years down the line, that point of time, you definitely need to do a FISH before starting the treatment. So how are genetic abnormalities are detected? So standard methods are the complex karyotyping, FISH, and NGS. So I just briefly mention few things. The genetic characterization of the CLL has made significantly progress over the past few years. And if you do conventional cytogenetic analysis, you can pick up only 40 to 50% cases. That is why the conventional karyotyping we generally don't do for the CLL patients. With modern molecular technique, particularly in the FISH, made it possible to identify chromosomal aberration in approximately 80% of the cases. So FISH now become, from the peripheral blood, it became the standard of care. But recently, another important issue of genetic risk classification in CLL was identified with the mutation status of the immunoglobulin variable heavy chain gene. So if I summarize these things, so 3 investigations: FISH for peripheral blood, IGHV mutation status, mutated, unmutated, and the TP53 mutation. These 3 is the complete set of prognostic investigations for the CLL to begin with. So FISH is a cytogenetic technique by which specific DNA sequences are labeled with a fluorescent tag and applied to metaphase chromosome or interphase nuclei. Fluorescent labeled DNA probe hybridizes to the specific DNA sequencing used to detect non-random chromosomal translocation, and FISH on interface nuclei require tailored handling procedure, and FISH is applicable on fresh and FEP tissue in contrast to conventional cytogenetics, which requires only dividing cells. So here 2 points is very important. So complex karyotype defined by the presence of more than 3 chromosomal abnormality should not be axiometrically considered unfavorable in CLL. And high cytogenetic complexity with more than 5 chromosomal aberrations emerge as prognostically adverse, independent of other biomarkers. So if you see these 2 graphs, that the first one, you can see that 5 or more chromosomal aberration. You can see that 0 to aberration, 3 aberration, 4 aberration, and 5 aberration, how the overall survival changes. So prognostic value in this FISH CLL, so that I described that, the 11Q and the 17P, the bad. And if you see the overall incidence, you can find that fortunately, the deletion 13Q, which is a good one, having a 15% incidence, and the median overall survival is significant, quite good. And you can see from this color graph that overall survival actually the changes when depending on the what type of FISH abnormality you are getting. So type of P53 aberration and its prognostic value. So loss of wild type P53 function in CLL can occur as a result of deletion 17P and T53 mutation. The most common cause of P53 aberration is a result of a combination of P53 mutation and deletion 17P, which accounts for up to 2/3 of all P53 aberrations. That is the reason you have to do FISH 17P as well as the P53 mutation, both together. Comparison of overall survival stratified by the absence or presence of 17P deletion and P53 mutation. And 17P13 deletion is invariably associated with the loss of P53 as confirmed by FISH technique. So how do you test these three issues? So I'll just talk about little bit about the FISH, Sanger, and the NGS. So FISH I already discussed with you. So Sanger sequencing is basically uses a selective incorporation of the chain terminating D-deoxynucleotides by DNA polymerase during DNA replication, and thereby creating sequence of various length, which are then separated by the size to derive the DNA sequencing. Advantage: simple, widely available, provide direct information of the mutation status, yes or no, can produce relatively long read lengths. High specificity, 93%. Disadvantages: time consuming relatively, limited sensitivity, and limited throughput. So I generally nowadays, when we do the mutational status at present scenario, most of the centers go with the Sanger sequencing. But I was just today morning when I discussing with the molecular scientists regarding this issue for the talk only, I'm very honest to you. So they are saying that we do Sanger sequencing, but we are very happy to use the NGS when the NGS will be standardized and validated. So advantage of NGS: high and customizable sensitivity, simultaneously analysis of a large number of genes. No PCR with some platform, very high specificity, 100%. The negative point: upfront cost of the instrumentation. Although some NGS sequencer are now cheaper than capillary sequencer like a Sanger, high throughput needed for the cost effectiveness. So definitely CLL with the unmutated and mutated status showed markedly different biological and clinical behavior. You can see from this graph. So mutated one is a much better. Mutated was is bad, and unmutated is good. So immunoglobulin gene analysis in CLL in the era of next gene sequencing. So I told you it is traditionally done by the Sanger's technique, but there is indeed a growing demand for the shifting practice and using NGS for the IGHV gene assessment. Although it is a debatable whether it is always justifiable, at least taking into account financial consideration for the laboratories with the limited resources, and obviously like country like India. And obviously the trained person to read the NGS is another challenging issues. So Sanger sequencing advantage: relatively cheap, relatively short tagged, adapted to solve small number of cases, data interpretation mostly straightforward, highly standardized. What are the cons? No insight into subclonal architecture and intraclonal diversity. No combination with other assay in one workflow possible. NGS: most detailed insight into both subclonal architecture and intraclonal diversity. Combination with other assays with one NGS workflow. Adapted to large number of cases. Circumvents need for laborious technique is cases with a biallelic rearrangement. Still relatively costly, little longer tagged, around 2 weeks. I think that is not a very important, because CLL is, we are not in a hurry to treat the patient, and need of dedicated bioinformatic tool, and data interpretation is more complicated and not yet standardized. That is the most important thing. So CLL in India is different from the West. There is a fantastic paper from the Renu Saxena from the All India Institute of Medical Sciences. So they believe, and their data shows, that in India compared to West, the bad cytogenetic FISH abnormality are more common. So high-risk cytogenetic abnormality like 17p11q was seen in the 13.3% patients in Indian population. And this is thus more common in India than reported in the West. Though mutation or unmutated status breakdown, break apart is almost same in compared to Indian and Western world. So if we decide about our treatment part of the CLL, the three parameters I think very important: whether these patients' general condition is good or bad, or they're frail, or their age, comorbidity. So that is the general aspect is extremely important. Whether these patients are 17p30 mutation status positive or not, and IGHV mutation status present or not. So if the frail patient with significant comorbidity, not able to tolerate purine analogs, or patient aged more than 65 years, and younger patient with significant comorbidities, without deletion 17p or TP53 mutation, I think the ibrutinib or acalabrutinib with a plus minus obinutuzumab can be a good choice. Venetuzumab, venetoclax obinutuzumab is another combination you can think about. So most important thing about the CLL management in today's world is a chemo-free treatment. That is one bottom line. Number two, many drugs are oral, which is another benefit of the CLL treatment. Whole world debated between the two things, definite treatment versus indefinite treatment. I think that is a very important and part in questions. And every time in the clinic, we encounter every hematologist in the world, whether in India or abroad, they are bogged down by this question, and patients all the time has their, all these patients wants a definite sort of treatment, because that is always easy for them to plan their life, plan their other activities. So that is a ever going on demand or challenges in the CLL management. So CLL with a deletion 1317p or TP53 mutation status. So I think it is very more or less is clear. So ibrutinib or acalabrutinib with plus minus obinutuzumab or venetoclax plus obinutuzumab, these are the standard way of treating this group of patient. So in India, we can get ibrutinib. In India, we can get acal, and if you push that, you can get venetoclax also in the country. So more or less, we get all these drugs. How to orchestrate or how to engineer this drug for particular the patient, particular group of patient, that is a real challenge. I somehow feel that as ESMO guideline is very elaborative. So they have a very nice way of classify the disease. So if you go, the IGHV unmutated, no TP53, no deletion 17p, if the patient is fit, I think the FCR can be a good choice. Advantage of FCR, difficult drug, difficult combination, no doubt in practice, but 30 to 35% patient can be completely cured with particular group of patient if they're given that. So this subset of patient definitely can be benefited with FCR. But if the unfit patients, I think your choice will be again the ibrutinib or acalabrutinib. IGHV mutated, no TP53 mutation or deletion 17p, fit patients, you can consider about the SIT, FCR or ibrutinib, or unfit patients, you can consider about the venetoclax obinutuzumab. TP53 mutations, all patients, I think the ibrutinib or acalabrutinib is a drug of choice. So if we summarize the whole stuff, that deletion 17p or TP53 mutations, all patients, obviously the ibrutinib or acal will be the better way to handle the therapy. If the patient is IGHV mutated, so then ibrutinib or acalabrutinib can be a choice. Venetoclax obinutuzumab can be a choice. chlorambucil obinutuzumab can be choice. And unmutated group, venetoclax obinutuzumab or ibrutinib or chlorambucil obinutuzumab can be choice. IGHV mutated with a fit patient, which is very important. Their FCR can be a significant number of patients can be cured with the FCR. And again, the fit patient, IGHV unmutated, ibrutinib can be choice. So key takeaway. So conventional cytogenetic analysis only detected chromosomal aberrations around 40 to 50% cases. So FISH, using the technique of the FISH, you can get 80% aberrations. And if in the way we are moving from the more towards the NGS technology very soon, when all the other logistics will be set in place. Genetic risk classification in CLL was identified with the mutation status of the immunoglobulin variable heavy chain gene. TP53 mutations are associated with a poor prognosis independently of the presence of the deletion 17p. It is important to assess for TP53 mutation status using a sequencing technique. NGS-based testing to traditional methods suggest that NGS may provide more detailed results. Thank you.
Thank you. Thank you, Dr. Subclones. It was an excellent overview of the list stratification as well as the management of these patients of CLL. You have covered almost whole of CLL in brief, so that we can build up on our next topics. So now our next talk is by Dr. Helen Flesig, who is the Senior Product Manager of Immuno-Oncology, Thermo Fisher USA. She will be speaking to us, and that is something, a topic of interest, might be somewhat difficult for us because we do not deal directly with these things, we deal with the results, but it would be interesting to know from her how IGHV testing is done and its importance in stratification in CLL research sample. Dr. Helen, please. You need to unmute yourself. Please unmute yourself.
That doesn't happen to me often. So thank you for having me. Just give me a second. I cannot share my screen until while the other participant is sharing, is what I'm told. There we go. There we go. Great. I'll share my. Okay, let's do that. Does that look all right?
Yeah.
Okay, perfect. Okay. So today I'm going to give you a brief overview actually of our entire portfolio for immune repertoire sequencing, and then I'm going to focus in on a specific assay that we've designed for CLL research specifically. So just really briefly, I think we all know that B cell receptors and T cell receptors play a really large role in the immune response. And, we have millions of different antigens that our bodies are exposed to on a regular basis. And we need a very diverse system in order to be able to respond very specifically. And in order to get that diversity, we have B cell and T cell receptors that have diversity introduced into them through recombination of their variable diversity and joining regions. And so sequencing those is referred to as sequencing the immune repertoire. And so Thermo has a number of assays that can be used to sequence the immune repertoire, and the entire portfolio is shown here. The original assays are the ones that are shown in the gray boxes, and they're really kind of focused more on translational research studies. We have some short read assays that prime for sequencing in the CDR3 region of the receptors and come in both DNA and RNA kits. And then we have 2 long read assays, which are also for use with RNA. So they give you a little bit of different readout, some additional information than you would get with DNA. But we extended the portfolio last year, and those are the assays found in the white boxes. And I think those are ones that are probably more of interest today. They're more targeted towards the heme-oncology audience, and they work all with DNA. And so we have 3 primary assays, being our TCR panclonality assay, our BCR panclonality assay, and then the BCR IGHV Leader-J Assay. The other three assays that are shown in the upper right corner, they're great assays, but they're really secondary or reflex tests for those first three. So in sequencing the immune repertoire, you have different types of analysis endpoints. So you're going to be looking at clonality assessment, somatic hypermutation in the case of B-cell receptors, and then rare clone detection. And rare clone detection is something that you're probably more familiar with the term of minimal residual disease, or MRD. In a research setting, we refer to that as rare clone detection. And so we're really going to be focusing today on somatic hypermutation with our particular topic. So let's take a little closer look. So we know that we need diversity in our B-cell receptor, and that we get a fair amount of that through VDJ recombination. And that happens in the early stages of B-cell development. And part of development of the B cells is they migrate to secondary sites, such as lymph nodes, where they have additional diversity introduced into the receptors through somatic hypermutation. And so that's just the process in which point mutations accumulate in both the light and heavy chains of the B cell receptor.
Dr. Helen, sorry to interrupt you. Your slides are not on a full screen mode. Can you please click on Use Slideshow button on the leftmost corner top?
I'm having troubles getting to that part of my screen. It's not working. Yeah, it's not really working. Sorry.
Yeah, that's fine, ma'am. You can go ahead with this then.
Okay, sorry. Yeah, it's not, I can't get my cursor. I have two screens and it won't let me go onto the other screen, which is where I need to go to do that.
Yeah.
Okay.
I think if you press swap displays on the second screen, Helen, it should swap it.
I can't even get to that.
Okay.
I think it's because I'm in Zoom and it's working a little differently, unless.
No problem.
Oh, there we go. Found another way to do it. There we go. Is that better? Oh,
Yes.
okay, perfect. All right. So going back to somatic hypermutation. So we know that somatic hypermutation plays a role in chronic lymphocytic leukemia, or CLL, which is the most common leukemia in adults. And since we have a growing aging population, globally speaking, it's something that's going to be seen more frequently. And somatic hypermutation has been found to be a biomarker for CLL. And the way that works is you're looking at the degree of somatic hypermutation, specifically in the heavy chain of the B cell receptor. And so the presence of SHM is generally defined as a mutation load of being greater than or equal to 2%. And so you can look at that as, they initially looked at it as looking at whether there is the presence or absence of somatic hypermutation, but really the degree of it is really important in being able to classify your samples. And so if you have mutated CLL, which means you have greater than or equal than 2% somatic hypermutation, your cells have a low proliferation rate. And if it's considered or classified as unmutated CLL, it means that your cells will have a high proliferation rate. And so because these somatic hypermutation makes a great biomarker, we have, there has been a focus on creating assays to be able to do analysis of this. And so a number of years ago, a group or consortium formed, referred to as the European Research Initiative in CLL, or ERIC, formed. And their goal was to create standardized and consistent analytical methods in immunogenetics of CLL. And there are, many different methods of doing this. Sanger sequencing has certainly been a popular one, but really we're trending towards using next-gen sequencing as a more standardized way of doing so. And so a little bit of history. Way back in 2007, the original primers for assessing somatic hypermutation in the IGH of the B cell receptor were the biomed primers. And so where they prime within the B cell receptor is within framework region 1, or FR1, which is kind of seen in the blue box in the up left-hand corner, all the way to the joining region, which is in green. And they use that for nearly a decade. And then in 2017, after doing additional research, Eric declared the FR1 primers to be unacceptable. They really determined that it was leading to underestimation of the mutational load because you're priming within FR1, so you're not going to be at the very end terminus of it. Additionally, you can have mutations being hidden underneath the primer itself. And so they started to recommend to prime in the leader region, which is upstream of FR1, and you can see that in that gray box on the right-hand side. And so research has continued because we're always trying to improve. And there is a group in France that published in 2020 a primer set comparison. So they compared the FR1 primer to the leader primer, and their results are suggesting that there may be guideline changes in the future, but the current recommendation still is to prime in the leader region. And so Thermo Fisher designed a assay wreath with these guidelines in mind. And so we have an assay that primes in the leader to J region. And if you use our Gene Studio system, it takes about 2 to 3 days of turnaround time to assess your somatic hypermutation. And one of the things with this platform that's particularly helpful for this specific assay is our platform has ultra low substitution error rates. Well, if you look at some of the competitor platforms, their actually mode of error is substitution errors. So you're ending up getting a higher mutational load than is actually happening because it's part of their error mode read. And the last part that's actually very helpful, and I'll show you a screenshot of it, is we actually have simple and intuitive analysis tools. So it's getting easier and easier to do. And just for awareness, we also have one of those assays that will prime in the original FR1 to J region as well. And that can be used as a reflex test if you have a very difficult sample when you run it with the leader to J. So when we launched this assay, we had an early access customer in South Africa called Oncolab, and they did some analysis with the assay. They ran 2 controls that are purchased from In Vivo Scribe. So they have a SHM positive control and then an IGH positive control, as well as 4 clinical CLL research samples that they had run previously with a different assay. And so in the middle, you're seeing a histogram plot. The amplicon for the Leader-J assay is very large. It's actually one of the longest amplicons we have in our portfolio. It comes in around 480 base pairs. And so you can see from the histogram plot that this is something that can be achieved with these samples. And the table on the right-hand side gives you an idea of what some of that readout looks like. And so some of the key features that you're getting from the analysis is, you can determine functionality, whether you have productive and unproductive reads. You generally are working with productive reads. If you have an unproductive, you may have to dig a little deeper into your data to see why that's happening. But you have a readout of mutational frequency, which is your SHM, degree of SHM in your sample. And so from that, this group was able to determine the status of mutated versus unmutated. And the controls, as you can see, worked out as you would expect them to. So SHM positive is considered mutated. That 12.3% matched what was shown on the lot from that particular tube as well. So that's good. And then the IGH positive control, you were not expecting to see any mutation in there, and we do have unmutated. And the 4 samples actually matched what was determined by the previous assay, so showing us that this assay is working well and that it can be run successfully on clinical research samples. This follows the usual NGS workflow, so you can collect samples from many different types of sample types. For this specific assay, we do not recommend FFPE samples just because it's a very long amplicon and FFPE tends to have slightly degraded samples, so they're not ideal. If you have really high quality FFPE, I'm sure it would work, but that's not going to be very common. You'll extract that DNA. You need about 200 nanograms, again, for this particular assay for DNA input to create your library. And you can load 4 to 8 libraries on a 530 chip. And when you run it on the Gene Studio system, you then go downstream and use our Ion Reporter software. And that software has several different report outs. So you'll have spectrotyping plots, you'll have CDR3 length histograms. And I think what really is probably the most useful is really the clone and lineage tables. just a brief snapshot of what some of those various readouts look like. So you can see all our different graphs. There's certainly more than this, but this is kind of a start just to give you that snapshot. And then focusing in on a clone summary table. So this is a follicular lymphoma sample. It's not CLL, but it does have somatic hypermutations. It's what I had available for you to kind of show you exactly what you're looking at. And so what you're looking at, where it says in the middle variable mutation, that is your somatic hypermutation frequency. And so you can see, the top samples have 7.5%. Mutational frequency. You can also, the frequency column further to the right, that is for clone frequency in this case. You can see where, under the variable column, you can see the assignment of where within the gene that sequencing occurred as well. And if you want more underlying data, there is a button shown at the top right that says download clone summary. You'll get an Excel file that has a lot of underlying data. So you can see just at a glance that this is actually really, it's really intuitive and simple to use, which is something that makes it a little bit easier to bring in for people with a little bit less expertise to be using next-gen sequencing. And so just in summary, we do have an assay called the IGHV Leader-J Assay. It is really designed to follow the ERIC Consortium guidelines so that you can use these assays for CLL samples. And we have an ultra low substitution error rate, so it makes our platform particularly well suited for this assay. And the simple and intuitive analysis tool should make it a little bit less intimidating to explore that possibility of going into NGS for looking at your samples. So thank you for your time.
Thank you. Thank you. Thank you very much, Dr. Helen. Actually, we got an insight into what actually you do. We always get the report, but what goes behind that was fairly evident from your lecture. It was a great thing to know, and thank you for your lecture. Thank you.
Oh, great. Thank you.
Now, we will move on to the next topic. Our next topic is the recent updates in the management of CLL or CLL treatment, and the speaker is none other than Dr. Pankaj Malhotra, who is head of the Department of Clinical Hematology at Postgraduate Institute of Medical Education and Research, Chandigarh. May I invite Dr. Pankaj? And let me thank you for being here, irrespective of your throat problem. And I must acknowledge that you are here as a commitment, even though I know that it was a bit difficult for you. And even now, while you are speaking, I know that there would be some issues, but thanks again for being here, irrespective of your throat issues. Thank you.
Thank you. Thank you. So sorry, I had very severe laryngitis, but hopefully I would be able to, do the justification. So just pardon my voice a little bit. So the topic which is given to me is about the recent updates in the treatment of CLL. So Dr. Sanyal has covered quite a bit of it. So my job is to complement some of the things which he has already discussed and present the Indian data, which is more important to discuss the local issues. So as already said, there are indications of treatment in CLL, and 30% of patients actually never require treatment. The indications are when there are progressive cytopenias, either because of the disease or autoimmune phenomena which are happening, like anemia, thrombocytopenia. There is a progressive lymphadenopathy. There are B symptoms like weight loss, night sweats, fever, or patient is having recurrent infections or organ dysfunction because of CLL. Now, the IWCLL has given criteria for active disease, and these, as already said, evidence of marrow failure or autoimmune phenomena, massive or symptomatic splenomegaly. Although in India, quite a good number of patients have spleen which is more than 6 centimeters. So almost, if you'll take this criteria alone, I would say that quite a good number of patients would be eligible for treatment. Massive nodes, that means more than 10 centimeter in longest diameter, or I think the more important thing is symptomatic lymphadenopathy. Then progressive lymphocytosis with an increase of more than 50% over 2-month period, or lymphocyte doubling time of less than 6 months. Now, I'm not very sure that whether somebody uses a lymphocyte doubling time of less than 6 months, because for that, you actually need to wait for 2 to 3 weeks and then calculate depending, excuse me, depending upon the WBC count, especially if they are less than 30,000. So that means if the counts is 20,000 and it has become 40,000, that does not mean that the lymphocyte doubling time is less than 6 months. So you have to calculate by a graph. Anyway, the next is autoimmune anemia thrombocytopenia that is poorly responsive to corticosteroids, and symptomatic or functional extranodal involvement like skin, kidney, lung, spine. And then the B symptoms, unintentional weight loss, significant fatigue, fevers, night sweat. Again, these are the excuse me, these are the parameters which I feel, it requires your clinical acumen. Many times we have seen that, the patients who are on wait and watch, they are obviously concerned about the disease. The doctor is not giving any treatment. So many times, they would complains of some fatigue or some other symptoms. And it depends on the doctor to see whether they are really, this patient really requires a treatment or he can wait and watch. So it's entirely on the CLL physicians who is looking after the patient. So now coming to the drugs, we have alkylators like chlorambucil, cyclophosphamide, bendamustine. We have corticosteroids like prednisolone, methylprednisolone. We have purine analogs, fludarabine, cladribine, pentostatin. We have monoclonal antibodies like rituximab, obinutuzumab. We have butane kinase inhibitors like ibrutinib, acalabrutinib, zanubrutinib. We have PI3 kinase inhibitors like idelalisib or duvelisib. And we have BCL2 inhibitors like venetoclax. Now, when you talk about the beauty of CLL is that you can combine these drugs, any of these drugs, with each other. So you have actually plenty of options when you really want to treat a CLL, and that's why this is exciting time for the CLL patients. And on top of that, we have cellular therapies like allogenic stem cell transplant or CAR-T, which is in experimental stage. Now, when you talk of advancements, so these are the advancements, about especially these three classes of drugs, butane kinase inhibitors, BCL2 inhibitors, and PI3 kinase inhibitors, and combination with antibodies. Now, if you look at the milestones in clinical CLL research, glucocorticoids and alkylators was the only drugs in 1950s. Then in 1970s, Rye and Binet staging came in. Then fludarabine was introduced in 80s. Then combination of fludarabine with cyclophosphamide, and bendamustine did come after unification of Germany. Then by 2010, we knew that the FCR leads to improvement in the overall survival. Then by 2014, the studies did show that there was a progression-free survival from the newer monoclonal anti-CD20 antibody like obinutuzumab in combination either with chlorambucil. Then kinase inhibitors actually came in 2010, but those were not successful. And when BTK inhibitors were introduced by 2013, and that was the landmark change in the treatment of CLL. And this was followed by PI3 kinase inhibitors, and then the second generation butane kinase inhibitors, and then BCL2 antagonists like venetoclax in 2016. And then the various combinations, comparison of these drugs in combination with the older drugs like bendamustine rituximab or clorambucil. So these are all the trials which we would see in subsequent slides also. Now, obviously, the question is how do you tailor treatment in a given situation? And as Dr. Sanyal has already said, you do a risk stratification, and we have a CLL International Prognostic Index for that, where there are different points which are given for the prognostic factors. And this is unmutated IGHV gene, which has been given 2 points. And a few years ago, this test, even in fact now also, are not routinely available in many of the laboratories. And you have listened to the excellent talk by the previous speaker. So what do you do actually if you don't have this test? So in Indian setting, this is one of the research paper which we have published in leukemia and lymphoma, that you use a modified CLL-LIPI using lymphocyte doubling time in place of IGHV mutation in resource limited settings. So excuse me, Helen, but this is what can be done in resource limited settings. So in this, we had the research from our institute. We had 471 patients, and you can see, and we are compared with a meta-analysis of CLL-LIPI. You can see the almost all the parameters are matching with each other, including the age, staging, and FISH. Already Dr. Sanyal has said, showed an abstract from AIMS where 17 excuse me, 17p was found in 11 to 15% of patients. We had our data showing 11%. In the West, it is 7%. And this is IGHV versus LDT less than 6 months. And you can see that almost if you would take LDTT in place of IGHV, this is mostly matching with that. And based on that, the risk stratification, if you do, almost this is matching with the CLL-IPI taking IGHV. So newly diagnosed CLL patient who does not meet the IWCLL criteria, so those patients, they should undergo age-appropriate cancer screening, dermatology or skin cancer screening, or whatever vaccinations. All patients should receive vaccination. Excuse me. And then once they require treatment, then you do a risk stratification based on the CLL-IPI, low or intermediate risk, monitor to them 6 to 12 monthly, and high risk, monitor them 3 to 6 monthly. This slide is already shown by Dr. Sanyal. I would re-show it, that somebody who has inactive disease, you don't need to give any form of treatment to that patient. But once it's an active disease or a Bennett C or I3 or 4, then if it is P53 mutation, then all other things becomes irrelevant. And these patients actually require either butane kinase inhibitors or VENG or VENO kind of a protocol. Whereas if that is not there, P53 is not there, then you look at the IGHV mutation, whether it is mutated or unmutated. Even though these guidelines suggest that in a mutated, you can consider giving FCR. But I would say that in India, we hardly use FCR. Now for the last, I would say 4-5 years, I have not used FCR in any of my patients because of the availability of generic ibrutinib or other drugs. And the patients who have low fitness, and again, based on the whether it is mutated or unmutated, you can consider VENG or VENO protocol or butane kinase inhibitors. And these are some of the trials which have shown the overall response rates and progression-free survival. FCR and BR, as I said, FCR, some people still considered as one of the good treatment, especially for patients who have mutated IGHV. But in India, as I said before, that it is quite toxic, and many patients actually are not able to complete the 6 cycles. And I would say 60-70% patient drop after 3 or 4 cycles. BR is one which is quite frequently used, and we will discuss where do we place BR in the current algorithm. Then chlorambucil plus obinutuzumab or chlorambucil plus rituximab. Ibrutinib in relapsed refractory or previously untreated, you can see a very good overall survival. For untreated, almost 83% at 5 years. This is what you see with the imatinib in chronic myeloid leukemia also. Then acalabrutinib, which is replacing ibrutinib very fast. In the West, it has already replaced ibrutinib. In India, because of the cost factor, we are still on ibrutinib. But again, you look at the untreated, 94% at 30 months, 95% at 30 months in previously untreated. And then venetoclax, though officially it is not available, unofficially venetoclax is available in India. So now coming to the Indian scenario, I will show some of the studies which we have published. I'm not showing any abstracts. I would show the publications in peer-reviewed journals. So this publication I already showed from our institute, where we had used the modified CLL-LIPI, and you can see the patients grouping into different categories based on the graphs. Very high risk patients have survival which is less than 2 years or so. And this paper actually suggests a real world data from for the last 8 years at our institute. We had 409 patients. The age, we still have patients who, I mean, 70% of patients are more than 55 years at the time of diagnosis. 70% are male, and almost 50% of patients have low socioeconomic status. And this is very, very important when we are designing treatment protocol for our patients. 42% patients are asymptomatic at the time of diagnosis. Most patients have good PS at the time of diagnosis, and the cumulative incidence, cumulative illness score is 55-56%, less than 3. And by age and median, it is, in the elderly age group, it is high. So rise staging system, if you look at that, so almost 40% of our patients require treatment at the time of diagnosis. FISH abnormalities, so 17p in 11% of our patients, and the other category 11q in almost 9%. So you can say 20% of patients are having high risk disease at the time of diagnosis. Another paper actually where we did purely cytogenic abnormalities. Here we had 13q as 42%. This is another, this was a paper which was published by our lab. So here again you can see the 17p were low, but again the patient population was different. So most of our patients receive chlorambucil prednisolone because 80% of our patients who belong to low to middle socioeconomic status, and rest patients received BR as the therapy. So we looked at the time to next treatment. So if you look at the chlorambucil prednisolone, even chlorambucil prednisolone patients are, for at least 4 years, they are doing good. So you can say approximately 60 to 70 months. Whereas patients who received BR, they have not reached the time to next treatment. So, so these are the rates. CRU unconfirmed 77% with BR, 3% obviously with chlorambucil. You don't expect CR in many patients. However, overall response rate 90% versus 74% in chlorambucil prednisolone. 50% of patients who receive BR develop neutropenia. So when you compare with the real world data, so we compared our data with the other studies which are available in the literature, and you can say the overall response rates. This is with BR, 91%, 96% in this study, 89% in this study. So almost matching with this, and median excuse me, time to next treatment not reached, whereas in other studies it is approximately 4 years or so. When you compare with chlorambucil prednisolone, so again, overall response rate 75%, 72% in this study, and approximately 3 years is the time to next treatment. So chlorambucil prednisolone is not bad, especially I think in Indian patients who are 75, 80 years with poor performance status. And this is the direct cost of diagnosis investigation. You can see when you are comparing with the United States, so these are quite cheap in India because of the availability of generics. So the conclusion from this paper was that the Indian patients with CLL are younger in chronological age but have higher morbidity burden, and the chlorambucil is still a valid option given the economic burden of the disease entry. So then we were, Dr. Sanyal showed you NCCN, where I don't know whether you paid attention or not, lenalidomide was mentioned as one of the drug. So we actually did a trial looking at whether in some patients we can use lenalidomide as maintenance therapy. So this was a randomized controlled trial last year in leukemia lymphoma. And we had 45 patients which were randomly analyzed, randomly allocated to either lenalidomide, increasing dose from 2.5 milligram to 10 milligram versus placebo. And we did not find much difference in these patients when they were given lenalidomide. Then we have this paper which is published in Indian Journal of Hematology and Blood Transfusion, reduced dose ibrutinib due to financial toxicity. This is when the original ibrutinib was available. Some of these patients, they initially started with 420 milligram, the standard dose, but because of the finances, the dose was reduced to either 2 capsules or 1 capsules. And this was very few patients, 3 patients only, versus the standard dose ibrutinib 12 patients. But the overall response rate and the median PFS were not significantly different between the two groups. And it is comparable to what you see with the full dose. And this is not unexpected. This is the paper from the West. This is from the MD Anderson, a low dose of ibrutinib and published in Blood. So again, they say the BTK occupancy, signaling and biomarker data show that a low dose ibrutinib after 1 full dose cycle is enough for biological activity. And these are other papers from, I think this is from Mayo Clinic. The impact of dose modification and temporary interruption does not matter in CLL patients on ibrutinib. And this is from another center. The dose reductions are not associated with the inferior outcomes. Then we looked at the efficacy, safety, and quality of life of generic versus innovator ibrutinib in our CLL patients. So these were 32 CLL patients, and treatment naive were 7, and relapse refractory were 25 patients. When you are using ibrutinib in relapse refractory patients, the chances of death are quite high because these patients are already, relapse refractory and they have poor marrow reserve. So this is an important finding which we should keep in mind when we are considering deciding therapy for our patients. So when we compared the innovator ibrutinib with generic ibrutinib, so the death rates were almost the same. So there is no difference whether you give innovator or generic. Important thing is that most of our patients, almost 50% of our patients, require dose reduction. And I'm sure Dr. Abhibhave, when he's going to discuss the panel discussion, this point he's going to bring out that almost 50% of our patients are on reduced dose of ibrutinib. And again, if you compare with the real world data, the death rates are same as in Sweden. So it is not that our death rates were high. So the quality of life, this is another paper which is published in European Journal of Hematology. We looked at the quality of life in 127 patients and looking at the cognitive functioning, emotional functions, and many other things. So quickly, the quality of life is severely affected in CLL patients on wait and watch. So this is very important. And this is what I was, telling in the initial slides that many physicians actually tend to start the patients on therapy because these patients are already, they are quite concerned about their disease when they are not on any therapy. Dr. Bhave is going to discuss about the allogenic transplant also. So this is one paper which we published from Mayo Clinic. This is around 12 years ago. So long-term outcome of allogenic transplant, basically to show that the allogenic, there is a very good graft versus leukemia effect, and this is an option when everything fails. And I will show in the algorithm. So I'm showing you British Society of Hematology guidelines, which are published just last month, or I think in this, last month or so. So the role of allogenic is currently is when you fail two out of chemoimmunotherapy BCR inhibitors or BCL2, irrespective of TP53 status, or if you have TP53 status, even if you failed one, you have to consider allogenic transplant in these patients. So these are the guidelines which I was telling you published just recently. These are the NICE approved guidelines, the venetoclax obinutuzumab, which Dr. Sanyal has already showed you. And for not NICE approved, so they use Acala obinutuzumab as frontline therapy. And these are some of the key phase 3 trials, Resonant Alliance. I think anybody can go into the literature and read about this. I'm just going quickly through this because there is no point in showing this data because this has been presented multiple times. I'm leaving this also because of the shortage of time, leaving this also. So yeah, so this, I think Dr. Abhay Bhave would discuss some of this in Indian setup. So this is the suggested algorithm for Indian patients. I think most important thing in our clinic is what is the socioeconomic status of the patient, whether he's low, middle or high. I have grouped into 3 only. The patient has a high socioeconomic status, you follow the Western guidelines, NCCN guidelines, British Society of Hematology guidelines, whatever guidelines, Western guidelines you want to follow. You want to give ibrutinib, acalabrutinib, or Venci combination, whatever, based on the TP53 and IGHV mutation. But as I said before, most of our patients belong to low and middle socioeconomic status. So I feel that chlorambucil prednisolone, chlorambucil rituximab, and BR, the time-limited therapy, especially if there is no TP53 IGHV mutated, these are still the options for our these patients. And if they relapse after 4 or 5 years, or after many years, then you can consider ibrutinib because it's a lifelong therapy. But if these patients have TP53 or IGHV unmutated, then you have to consider ibrutinib as the therapy. So finally, there is a great progress in the field of CLL, especially in the last decade, and risk stratification is very important, FISH and IGHV mutation at least. Asymptomatic, still wait and watch. Symptomatic, treatment is based on FISH and IGHV mutation. Ibrutinib obviously for high-risk patients. I feel benda-rituxi, chlorambucil-rituxi or chlorambucil prednisolone is still good for patients who are, Ayushman Bharat or low socioeconomic status patients. And the generic ibrutinib has similar efficacy as innovator. With that, I thank you very much for your kind attention.
Thank you. Thank you, Dr. Pankaj, for a great lecture. I must admit that it was good to see the Indian data, which helped us to make decisions in our practice regarding the patients who may not be able to afford. Before I move on to the panel discussion, I've got a few questions in the chat box. Dr. Helen, if you are there, may I ask you these chat box questions? Dr. Helen, please. Okay, so she's not there. So let us see.
I am.
You're there.
Here, and I'm not sure if Helen.
Okay.
So I'm happy to take these questions on Dr. Helen's behalf, if that's okay.
Yeah. We want answers.
Yes.
So basically, there is a question regarding the percentage of this mutation to say that it is IGHV mutated or not. If it is a borderline value of something like 1.9 or 2.1, what you would like to declare it as?
So I think that the same for NGS, and I speak about NGS in general here, and not our assays. But in general, you would be following the same guidelines. So I think if you follow the ERIC guidelines in India for reporting these, I know they always say for these borderline cases to report them with a caution, with a cautionary note of these are borderline cases. And I think cutoff for borderline is it 97 to 97.9% identity to germline. So I think it's the same in NGS. You consider those as borderline cases and report them as such.
And there is a second question, where Sanger sequencing still being the gold standard, what would be added advantage of performing IGHV testing using NGS when our clinical decision is routine practice is not dependent on subclonal architecture?
Yeah, I think this is a fantastic question. And from a company's perspective, coming from Thermo Fisher Scientific, I'm from the medical affairs team for those. I didn't introduce myself, so I'm sorry. It's an interesting question, and I see lots of debate about this among people like yourselves discussing whether or not the time to move to NGS is now. Just on a practical note for next generation sequencing, because, for example, the next generation sequencing assays that we make are amplicon based and then multiplex PCR based, often there can be an improvement in producing a product which may be missed with next generations, with the primers that you might use for Sanger sequences. So you have an added advantage that it can maybe pick up more cases that are sometimes missed by using the standard primers. So that's definitely a technical reason for moving to them. Of course, there's a wealth of information that is provided within the sequence. Sometimes you can sequence more than Sanger sequencing, and being able to see the mutations against background can also sometimes be easier to interpret. But I'd be interested to follow that discussion among this group about reasons to move to NGS and when the time to do that is right.
Thanks, Kathleen, for those answers, and thanks, Dr. Rishabh Bhalla and Dr. Neeraj Garg for putting those questions. And before we go on to panel discussion, let me have one question for Dr. Pankaj Malhotra. Dr. Pankaj, are you there? Dr. Pankaj. Okay. So if not, we will move on to the panel discussion. The next our session, the next part of this event is a panel discussion which is conducted by Dr. Abhay Bhave. We all know Dr. Abhay Bhave. He is a hematologist, senior one, well-known, practicing at Leela Hospital, Mumbai. And I request him to take over the panel discussion, invite the panelists, and proceed with his job. Thank you.
Thank you very much, Avinash, for the opportunity to interact. So we've got a fantastic panel. You've already heard some of them speak, and you're now going to hear more of them speak. We've got Dr. Helen Fleissig, who has already spoken. She's the Senior Product Manager, Immuno-Oncology at Thermo Fisher in the United States. And we'll also be glad to have Kathleen Gilmore take some of the clinical questions if there are. We've got Dr. Arshad Raja, who's an Associate Consultant in Hematology and Hemato-Oncology at the Kaveri Hospital in Chennai. Dr. Sanyal has already spoken beautifully. He's the Director of Hematology and Transplant Services at Fortis Hospital in Mumbai. We've heard Pankaj Malhotra, who's the Head of Department Clinical Hematology at PGI Chandigarh. And we're also happy to have Sandeep Shah, who's a Consultant Medical Oncologist and Hematologist at HOC Vedanta and at the GCRI. So with this panel, if I'm allowed to share my screen. And I'm assuming you can see my slide. Can my slide be seen?
Yes, yes.
Okay. So thank you very much, Avinash, and I thank the Indian College of Hematology for asking me to moderate this very elite panel on CLL. And we are all discussing as part of the advances in biomarker testing. So we'll go on to our first question straight away. And I'll present this question to Dr. Sanyal, that both you and Pankaj have spoken about asymptomatic CLL not being treated. But in CML, with the slightest increase of white cell count, there is a need to start on TKI inhibitor. What has BTKI done wrong when patients have got CLL, and even if they're asymptomatic? Would you want to use them? What's your thought on it?
Yes, sir, it's a beautiful question, no doubt. So for our conventional CLL teaching, we know that around 35% patients don't require any treatment throughout their life. So basically, if you see around, say, 50 to 60% patient ultimately need some form of therapy in their CLL journey. So which is a 35% number is a huge number, number one. So standard practice in the CLL is to still go by the standard criteria of the B symptom, significant adenopathy, significant splenomegaly, autoimmune issues, significant cytopenia. So these are the very basic standard ethos of the philosophy of the CLL therapy. So in asymptomatic CLL patients, I don't feel that we should start unless or until we get a very robust clinical data, which will be totally different from the philosophy of the CLL, what we practice today. So that is the whole question. So I honestly don't practice any sort of oral BTK inhibitor in asymptomatic CLL patient where they don't fulfill the criteria of the indication of the treatment.
Right. Thank you very much. I think if you talk to patients, and I think both you and Pankaj have alluded to the fact that the patients are extremely anxious when they see the report and you tell them that you got a cancer and that you're not going to treat. So it's really hard. It needs a lot of counseling to these patients. If you look at early intervention trials, there's this phase 3 trial to look at early stage treatment of CLL patients with disease that was not indicated for treatment. And they were treated either with ibrutinib or placebo. And you'll see that the event-free survival was 47.8 in the placebo group, and it was not reached in ibrutinib at a follow-up of 31 months. And the progression-free survival was 14.8 months and not reached in the placebo, in the ibrutinib group. And the incidence of adverse events were not too different. So actually, there is a study which shows that early intervention can provide clinical benefit to patients with CLL. I'm not advocating it. I'm just saying there's a trial, there is clinical data. So it can be used for those people who need it. All of us say no, we are not going to use it. And this is because due to the absence of a defined survival advantage to early treatment intervention, therapy is generally not initiated. That's the reason why. And don't forget, we can face short-term toxicity, although it's popping a pill, but this pill has both short-term and long-term side effects. And effective therapy can still take place even if the patient becomes symptomatic at a later date. So there is no disadvantage. And these are the points that we have to tell our patients, the reason why we don't initiate therapy upfront. And already Pankaj has told us what is the criteria for starting treatment. And they are the same that he has shown. I'm showing the same over here. Either Dr. Helen or Dr. Caitlin, you can take this one. You spoke of IGHV mutation, and Pankaj did show some data in Indian, but just tell us what's the incidence of IGHV mutation in CLL, and is it a feature that is seen only at the time of first diagnosis? If it's negative, can it happen in relapse? If it's positive first time, can it become negative? So what's the look at IGHV mutations?
Hi, I'll take this question if
Sure.
that's okay. So again, it's an area that we're interested to hear from everybody on this call today as well. But it was interesting for me because I know the incident rate of IGHV unmutated in CLL is around 40% in the global population. And I wasn't sure about the Indian population, but somebody presented that earlier. So I saw that, I saw briefly it said 36% or near enough the global incidence. So I think that is the incidence rate that we're looking at for unmutated CLL, which of course has the poorer prognosis than mutated CLL. Most clinicians, I understand this, do the IGHV mutation testing up front because it's used to inform the decision-making process for those patients when treatment is going to be applied. And I think many of the recommendations that have been shown today suggest upfront testing. In terms of relapse, we know that IGHV mutation status tends to be stable. So because the same clone, there's no way, it's very, very unlikely that you would have a change in your IGHV mutation, somatic hypermutation status at relapse. So it doesn't need to be performed at relapse. Of course, this is different to the other somatic mutations like TP53 and other mutations, resistance mutations, particularly with the new novel agents that are being used up front in CLL. That's a very different circumstance, and those mutations should be tested for at relapse. But IGHV, my understanding is that is stable, so it doesn't need to be done at relapse as well.
Right. Thank you very much for that. We do know that from whatever literature I could gather, the prevalence of this mutated IGHV is higher among the newly diagnosed and asymptomatic patients, about 60%. In the, it's about 50 to 60% or 70 to 80% in the relapsed refractory patients. And like you said, IGHV mutation never change over time and thus represent the fingerprint of the disease and are associated with a better response to some treatments with prolonged survival. And those who are mutated, for us clinicians, it's very important to know IGHV because for those who are mutated, the progression-free survival is far superior to unmutated, as also the overall survival. So for us, it makes a huge difference knowing the IGHV status in our patients. So I'm going to come to Pankaj. Pankaj, this IGHV status, you have already given this answer. You have said you're not a major proponent for FCR. And even I'm not. So is it now time that we switch to the newer agents? But on the other hand, the newer agents are not easily accessible financially to us. So there are two questions here. We know that FCR has got a great response, but it has side effects. On the other hand, the chemotherapy agents, other non-chemotherapy agents, including BTK, may not be in the every common man's ambit. So in terms of approach, are you going to give FCR to some cohort of patients still, say maybe the young, fit, who are uninfected? Or now FCR, you've written the obituary and you've gone on to the newer novel agents? Pankaj, are you there? Am I missing Pankaj? I know maybe Pankaj is not around. He wasn't too well anyway. So he gave a beautiful lecture. And I think he's already told us that he's not a proponent for the FCR. And if it was possible for us today to use novel agents, then probably we would go for it. I'll just show you some additional data. CLL patients benefit from ibrutinib and idelalisib, although idelalisib is not available in our country, independent of the IGHV mutation status. And the treatment with ibrutinib, the progression-free survival of the unmutated or mutated is similar. So I think ibrutinib is a drug which is completely changing the paradigm treatment of CLL. And maybe there'll be a time, sorry, Helen and Caitlin, we might actually not ask for the IGHV, look at the lymphocyte doubling time. And then as soon as the patient is symptomatic, with the generic form of ibrutinib being available, it might be a great option to use this upfront. I'm going to show you quickly 2-3 trials where I'm going to show you the role of the novel agents in patients who are mutated, unmutated. You see in this ECOG 1912 trial, where ibrutinib with rituximab was compared with FCR in the younger patients, which was the forte of FCR. Deletion 17p was deleted, and you'll see that there's not much of difference at the end of about 3 years of treatment between the two arms. There was a statistical significant improvement in 3-year overall survival in the IR over the FCR. Similar thing was seen in PFS, but one thing we must say, that the PFS advantage for the unmutated IGHV did not match the mutated IGHV. So PFS may not be, but in the overall survival, it seemed to be doing well. And when it was last presented in the ASH annual meeting in 2019 at a 4-year follow-up, IR continued to demonstrate superiority in regards to overall survival, and also it began to show improvement in PFS. Therefore, it's a very good drug to use, including those who had unmutated IGHV, which was initially, we didn't know what to do with it. Acalabrutinib. In the Elevate TN trial, clearly the AO combination, acalabrutinib with obinutuzumab, demonstrated improved estimated 2 years progression-free survival over chlorambucil with obinutuzumab across pre-specified groups, which included unmutated and mutated. And you'll see that the responses are brilliant, including for the dreaded deletion 17p. So it appears that, like has been shown, that irrespective of the age, and especially for those who are, it makes no difference really, fit or unfit, as time goes along, whether they are mutated or unmutated, we are going to go to the novel agents. And this is what has been proposed. And I think even Sanyal showed this, that we'll be going to a combination like venetoclax or obinutuzumab over a period of time. The problem is, as Pankaj says, we cannot handle the cost. It's going to be a major problem for us to combine a BTKI, even if it's generic, with a monoclonal antibody, because that's the expensive one. We may not be able to handle it. And the truth about IR is that even if both are generic and easily available, the number of patients who have dropped out of the trial with IR were extremely high. I think it was the Alliance trial. It was high because of the side effects that are seen with IR, especially infections. So although it might sound great, but it may not be really what is happening in the real world. But it looks like novel agents will slowly take over from a chemoimmunotherapy, and CIT will be a thing of the past. We'll not be using that. If Sandeep is there, I can ask Sandeep the next question. We are now speaking about finite therapy for patients who are in the upfront treatment, because when you tell them about BTKI to be taken long-term till disease progression or resistance, they get majorly put off. And I know that you and I are using BR, we are using chlorambucil, and they are finite, because you could use BR for 6 cycles and then leave the patient alone. Some give maintenance, some don't give maintenance, but that fixed combination is there. But if you are not using BR and chlorambucil, then are you using a finite therapy for CLL, especially with the newer agents? And have you stopped therapy in these people?
No, as we see this combination of Ven-G, we all like to use this finite therapy in our patients, but unfortunately, because of the cost, and venetoclax is not available in India, so I have not used till this finite therapy, which is recommended. This newer agents combination of obinutuzumab and venetoclax. I would like to add that we are still using FCR, which is a finite therapy, and I think we don't have problem to handle these FCR toxicities. And there are toxicities with ibrutinib also, there are toxicities with venetoclax also. So, but as far as venetoclax and obinutuzumab is, we have not used it. Mainly the cost is the main reason.
Can I extend the question to any other panelist who wants to answer, whether they have used finite therapy with the newer agents, or what is their thought? Would they want to use newer agents?
So, sorry, I was not there.
Yeah, Pankaj. Yeah.
So as I discussed in my talk, majority of our patients, I would still feel belonging to low to middle socioeconomic status. a finite therapy is a good option for them. Because if you are giving ibrutinib to them, let's say generic ibrutinib, at 5 years, only 60% of patients are going to remain on ibrutinib. What would you do, to 40% of patients? Can you give, if the ibrutinib failure is there, can you give BR? Can you give chlorambucil? I don't think so. So I would say that you reserve ibrutinib for, all these patients, especially who belong to low to middle socioeconomic status.
Right. Okay. So there is a changing paradigm. You'll see that there are some which are phase 3 trials, which are frontline approved by FDA for unfit patients. You'll see here obinutuzumab and venetoclax 12 cycles and with great responses, as opposed to others who are using ibrutinib or chlorambucil on continuous basis or fixed dose of rituximab. You'll see that the responses are fairly similar. The progression-free survival is also fairly similar. Therefore, it would all depend upon who's sitting in front of you and what kind of, unfortunately, what kind of science fits the finances of the patient. So otherwise, we would love to have a finite therapy where the patients feel that they'll get off the therapy. Likewise, for fit patients also, we're already using finite therapy as been discussed by the panelists, whether it's BR or whether it's FCR, we are using them with great responses. Yes, there are infections. Yes, there is myelodysplasia. Yes, there is inability to give all 6 cycles of FCR. But for India, all 3 are available as generics, and they are a fantastic combination for those who are fit enough to be able to handle it. But as time goes along, these phase 2 trials are going to give us more information about chemo-free regimens, and which are going to be in the form of various combination of novel agents, which are shown over here. And as time goes along, we are going to get more and more newer agents, especially in the BTKI. And there's going to be more and more specific, less side effects. But by the time it comes to India to use, it's going to be a long time because of the costing. But the beauty about them is that they look at minimal residual disease, how deep they can go. And obviously, they're going pretty deep. And they are for limited period of time, which is very good for, say, a patient who's in India. We are seeing as young as 45, 50. So for them, it's great news that they can get off the therapy. So we'll come to the next status, and that is, everyone speaks about MRD, and for clinicians, that MRD becomes very important. We know that in myeloma, the MRD status was discussed, but it is not standard. It's still in clinical trials, and no one decides end of therapy based on MRD. But in CLL, there is data in terms of MRD status. But can India handle the MRD? Because when you talk of MRD, there's a lot of questions that come up. How should you define it? Is that the goal that we want? What's the cost of doing this MRD? What's the cost of achieving MRD? Kind of medicines you have to use are very expensive to be able to get it. Is eradication, MRD eradication a surrogate marker of a biologically favorable CLL? Is there any advantage in treating CLL until MRD eradication? How long should you continue? So I can just keep on asking you questions, but I'm hoping that Dr. Arshad Raja can give us some more information as to how he looks at MRD in CLL and does he follow it?
So right now, like MRD in CLL, I think nobody in South Downtown is practicing. Like in Chennai, none of us do go for a MRD in CLL, and we don't know, like it may give us an idea that if MRD is negative, patient may have a longer PFS, but whether to decide on the stopping of therapy, still it's a question mark only. And there was, I think recently there was a ASH abstract also on that, they did a study combining zanubrutinib, venetoclax, and obinutuzumab, where they had determined the MRD negativity based on the MRD kinetics, something called as MRD kinetics. So they did a MRD at beginning of cycle 5. And if that peripheral blood MRD is negative, then they could definitely say, okay, this patient is going to have a sustainable MRD negativity. So you can stop the treatment at 8 months, something like that. So these studies are yet to be fully approved. I think definitely maybe in the future it may gain a significant advantage. And as of now, we are not practicing MRD, especially in CLL.
Thank you very much for that. But we do know that as far as MRD is concerned, the deeper the response, the better it is. because the progression-free survival is excellent for patients who have achieved a deep molecular response. But we must remember that we should do MRD only for those patients whose the therapy was with the intention to be, aggressive. So you can't do MRD for an ibrutinib patient because this patient is going to take it for a long period of time. So choice of the patient is very important. You should do MRD for patients who are going to take finite treatment, where we are going to be marrow centric and we're going to have a depth of response. It is only in them that we are going to do. And they, as you all know, there's a difference between bone marrow and peripheral blood MRD status. So there is a gap between the two. So one would first do a peripheral blood MRD. If it's negative, then attempt a bone marrow MRD to confirm that it is indeed negative, because there can be a 15 to 30% difference. You might have a peripheral blood which is MRD negative and still have a bone marrow which is MRD positive. And the main problem is, what do we use as MRD negative states? I mean, all our laboratories are not as good as some of the Western laboratories that can give us data, even if the turnaround time is 3 or 4 weeks. We don't know what to use upfront. We sometimes don't have the upfront data to decide what is the MRD status to be determined. Although there are trials and methods, but I think for India, it's very nascent for us to think of MRD, and I agree with Dr. Arshad Raja. So while I have Dr. Arshad Raja speaking, can you tell us how you manage side effects or cytopenias? Because ibrutinib being available as a generic and now acalabrutinib also in the market. So people who are taking this, they have cytopenias and side effects. How do you handle them?
So the most common side effects we see, some bleeding manifestations, some may land up with cardiac rhythm abnormalities and hypertension with the acalabrutinib. Personally, I have seen only one case, and other things like infections and cytopenias can occur. So with regards to bleeding, like if a patient is having more than grade 3 or grade 4 bleeding, and if it's a deeper bleeding, not like a superficial bruise or anything, obviously we have to consider reducing the dosage of the ibrutinib. Starting from 420, we can cut down one tablet. You can switch down to 280 or maybe even lesser if the bleeding continues. And if the patient is already on antiplatelet, yes, definitely you have to be very cautious on the going on the full dosage of the treatment. And if patient is already on vitamin K antagonist or something like that, definitely withhold BTK inhibitors. That is the dictum. And with regards to atrial fibrillation also, if patient has a past history of atrial fibrillation, we can still go ahead with the use of the BTK inhibitors. We still go ahead, and patients usually tolerate it well. And if on ibrutinib patient develops AF, then we have to coordinate with our cardiologist also. And based upon the Chadwa score and bleeding risk, we have to accumulate like whether we have to continue ibrutinib or we have to withhold. And if patient is needing anticoagulation, yes, definitely withhold the ibrutinib. And with regards to infections, yes, if a patient has severe infections, fungal infections or anything, definitely we have to consider withholding ibrutinib. And hypertension, they don't advise holding the BTK inhibitors. We usually continue with the BTK inhibitors. And cytopenias, usually we don't hold BTK inhibitors. We just give some 1 or 2 shots of GCSF and continue with ibrutinib.
Right. So it would depend upon the depth of the cytopenia and the clinical manifestation of the cytopenia before you decide to dose reduce. Because on one hand, you do want to continue the BTK because there was a need. The patient was symptomatic. But on the other hand, you don't want to end up with a situation where you get an adverse event which could affect the health-related quality of life of the patient. So you do that. And I think Pankaj has shown us beautiful data that dose adjustments, dose reductions, and dose continuations can be done. So you can actually reduce the dosages of ibrutinib and see how your patient is responding. And if the patient continues to have cytopenia, you can actually dose discontinue for a while and then reinstitute that drug, maybe in a ramped up manner to see how they do. And sometimes they actually are able to do quite well and go back to the full dose, just like we see in imatinib, mesylate, and with nilotinib and dasatinib. Sometimes initially there's a drop, and then they plateau out, and then they pick up, and you can go back to the full dose. So you should try those combinations and see whether it works. In terms of acalabrutinib, my problem is that it's a twice-a-day drug, and many of our patients end up taking once a day, and the PK/PD does not support once-a-day therapy with acalabrutinib, unlike ibrutinib, where you can come down from 3 to 2, or even 1 for that matter. And there is even Swedish data for dose reduction with ibrutinib. And many of our patients have learned it over a period of time. They actually reduce it on their own without telling you, and they still get a good response, and they are very happy to take less of the drug. But these could be some of the ways that we can overcome the side effects of, and I fully agree with you about hypertension. You should aggressively control the blood pressure rather than reducing or stopping the BTK, irrespective which one you're using. The only problem comes with atrial fibrillation. DOACs are the preferred ones with ibrutinib, as opposed to, say, aspirin. And if you have to use an antiplatelet, please use clopidogrel rather than aspirin. Pankaj, I'm going to come.
Sorry.
Yeah, sure. Yeah.
Can I take 1 minute? So
yeah, please.
Yeah, I think the cytopenia part is very nicely described. Recently, I was going in the literature. So if your WBC count comes down to a grade 4 neutropenia, so less than 500, then you stop for a time, and then just you can restart when the WBC count more than 1,000, and you can restart the same dose. Is at the 420 milligram. So if it is happened second time, just come down to 1 dose lower, so 280. If it is again third time, become with 140. And if the 3 times this problem happens, you can discontinue the drug.
Okay. I think we would do the opposite way, most of us. I don't know. That's what I do. I go up gradually, I ramp up. But for the sake of time, because we've got a limited time for this panel, and we've already overshot the time period, I'm very sorry. Avinash, my apologies to you, but we'll take the next question from Pankaj. Pankaj, quickly tell me that, you got a very busy OPD in PGI. Do you get enough time to counsel your patients of the different, now there are so many drugs. I find it very hard in the private sector. And once you tell them, how do your patients respond? I mean, do they go by what science dictates? Do they go by what finances dictate? Or they go back with more questions?
So patients who are well educated, they require a lot of time, and it is not one counseling session. They require multiple counseling sessions because there is nothing no urgent treatment required in CLL.
Sure.
So that's why for a patient who is well educated, who has read, he would like to know all the options, and they take time. But for majority of other patients, you do discuss the options with them, but most of the time it is the finances which dictate the treatment of the patient. So this is how we do in the OPD. And I would just take you back in the previous question. So I actually agree, Dr. Abhay, with you. This is what we do. Dr. Sanyal, what I would say is that when ibrutinib came, and when it was shown a reduced dose is effective, the company stopped manufacturing 140 milligram in the West because they thought they are getting the, obviously the business is going down. So many times in the literature, the West would give you the data, which is mostly company driven. I would say you go by your judgment, your experience. I feel a reduced dose ibrutinib is very good. And we have now experience for the last many years to see that these patients do very well on reduced dose of ibrutinib. And I agree with Dr. Abhay, what he said in the previous one. Thank you.
Great. Thank you very much for that. Just for Helen and Caitlin, we'll tell you that most of the times when our patients, after the discussion, they get up and they say, doctor, whatever you say. So, the entire science, discussion, trials, data thrown at them is promptly thrown back at you saying, doctor, what should I do? We will do whatever you say. And like Pankaj very rightly said, that for those who are discerning enough to understand the finer aspects of it, we have to spend more time. But for the majority, they'll say, doctor, whatever you say. So sometimes the counseling in India is a little bit different. Sandeep, I'll come to you. In terms of CLL treatment, we spoke about some drugs which are available for Indian financial status, some drug which those who are affording can use. But are you finding some unmet need in India in terms of availability of drugs or drug combinations, maybe even trials? What's your level of satisfaction with what is available to us in CLL?
As far as I think CLL is concerned, only drug which is not available is venetoclax. And so if you want to use this finite therapy, venetoclax has to be available.
Right.
That venetoclax available from Bangladesh or Sri Lanka, I think that is very difficult to say whether it is working or not working, and to prescribe it is very difficult. So I think once venetoclax is available, I think most of our problems will be solved. And those who want finite therapy, definitely that is the best combination which we can use, venetoclax and obinutuzumab, if patient has money and they want to spend it.
Quite right. Actually, venetoclax is changing the way many of the diseases are going to be treated.
And it will be more used in acute myeloid leukemia rather than CLL.
Yeah, I mean, it's there everywhere, isn't it? It's there in myeloma for 11, 14. It's there in AML. It's there in CLL. It's going to be there in all low-grade lymphomas. So it's a great drug to use. So there are trials going on for second-line therapy, either alone or in combination. And we've got the phase 2 arm and the Murano trial, which you just spoke about, the VR protocol. And it's done extremely well. So yes, this is one thing we are missing, and hopefully we'll get it to the point that now in frontline treatment, where we're going to start using BTKI, most of the countries have gone to BTKI for first-line treatment. There's no doubt that if there's progression or intolerance, as long as there is intolerance, then maybe you can switch to acalabrutinib. But if there is progression or resistance, I doubt acalabrutinib is going to work where ibrutinib already has become resistant. In that case, you will need, and you see here, irrespective of what, the VR protocol is going to become the way we go in terms of future therapy for patients who are, because more and more of our patients are going to take BTKI, and there's going to be a point of time in our Indian population where people will become resistant because they were young to begin with when they started.
Yeah. As far as venetoclax is concerned, it has got an additional advantage of getting deeper MRDs.
Deep response. It's very narrow-centric.
As against the BTKs, where they do not leak. So basically, venetoclax is a good drug to achieve greater MRD, whereas BTKs do not achieve that, and therefore now the trials which you showed are coming up with a combination of these two, BTK plus BLC2.
Absolutely, I take your point very well, Avinash. And venetoclax, being a BCL2 inhibitor, is more lytic to the marrow, causes significant marrow suppression, and that's why when we have to use it, sequentially, and it does extremely well. So Pankaj, coming back to you, if your patient were to relapse, which is I think inevitable in CLL, do you treat them immediately? You wait, watch. What do you do?
Again, wait and watch.
Right. Okay. So there are criteria who should be treated. Symptomatic relapse should be treated. Asymptomatic, like Pankaj said, can be just looked at or observed. But one thing is true that if there's a relapse, then pathway inhibitors are going to be better than CIT, unless the relapse is like 3-4 years down the line, in which case you could go back to the first CIT. For example, if you use let us say BR protocol, than that. And then, of course, you look at various aspects like patient-related, disease-related. When was the prior therapy? What are the response to prior therapy? What are the side effects? All those things. Now, we'll come back to Dr. Helen and Dr. Caitlin. We spoke of IGHV, we spoke of deletion 17p. So do you foresee some other biomarkers coming out which are going to, from a drop of blood, give us much more information, either to diagnose or to treat differently, or to monitor for an early relapse?
Hi, I think this is a really interesting question. I'll try and keep this brief because I know we could probably spend another hour and a half just speaking about this, and unfortunately we're limited on time today. Certainly circulating DNA, from what I've been reading and seeing, I think that this does offer a novel opportunity and an interesting area to really be able to dissect out those cases that may relapse, maybe being able to detect clones that are in the lymph nodes that are shedding their DNA and being able to identify those in the plasma. This does seem to be an interesting area of research. And I think that this is largely driven by all these novel agents that we're speaking about, I think they're more likely to generate resistance mutations. This is common in drugs that are very, very effective, of course. So I think circulating DNA, yes. And in terms of resistance mutations, I could envisage a world with all these incredible treatments and combinations that we can see and the different recommendations and things. I can envisage a world where it might become important to monitor those resistance mutations more closely. So for something like venetoclax, the BCL2 inhibitor, looking at those emerging resistance clones that do seem to be appearing under certain circumstances, so that maybe therapy can be changed and adapted throughout the course of the disease.
Thank you for that, because when we speak of MRD, everyone speaks of doing MRD in peripheral blood and bone marrow. But many times there are still lymph nodes, and those lymph nodes can still shed the DNA. Which may go undetected if you're doing by MRD for a specific set of primers. So that also becomes important, and I think the future circulating DNA will become an important biomarker. Dr. Sanyal, I'm going to come to you now. The CAR-T is the flavor of the month. CAR-T in CLL? Yes, no? Sometime in the future.
So data in the CAR-T at present, I think, not very great. Among the entire B-cell basket, I think it is almost the lowest bottom, the response rates are. It is strictly within the clinical trial. I think the multiple relapse patient with all the BTKI, all the idealism, everything actually failed. So that is a situation of the CAR-T now. So I think not in near future, maybe in distant future.
Okay, so there was some study with Lizocell, which was the CD19 directed CAR-T therapy for relapse CLL. And it was the phase 1 Transcend CLL 004 study. And it's very impressive. I mean, it's early days, a very small number of patients. But like you very rightly said, these are relapsed multiply with multiple lines of treatment. And there's a 45% CR rate and 80% or more have achieved undetectable MRD, which is something which is phenomenal. I remember a cartoon where they showed that for CAR-T, when all the CAR-Ts were running behind some disease, the CLL had fallen down, showing that it's not working so well for CLL. But when you see such data, it is a promising therapeutic modality and will eventually have a role in this disease. My last question, I think Pankaj has spoken about this. So if anyone wants to speak more, has anyone done a CLL transplant?
I think I have not done any CLL transplant. And I think all over India, hardly 2 or 3 transplants are done in CLL.
So I'll ask Pankaj, he had showed some data on allogenic.
Yeah, we have done one, but that patient actually was in Richter transformation.
Right.
And and that patient was quite young, I think 32 years old lady, 32 or 35 years. So, but she was in Richter transformation. We tried to bring her into remission. She was not in complete remission. We did the transplant, engraftment was okay, but she relapsed by day 40 or day 50, and then she could not make it out. Okay.
So lots of new things are going to come in CLL, which I'm showing you here. There is also going to be the higher generations of BTKIs, Zanu, Perto, Veka, Tira, lots of them. And Perto is looking good because even for ibrutinib, when venetoclax failure, it's there. And there's this U2 protocol, which is not a group which sings, but it's obinutuzumab and umbralisib, which is making huge waves in terms of its responses. The future of CLL will be seeing more novel agents and many other protocols that will come up. So from what we have discussed in this panel, we are not going to treat them early. Even if we have BTKI, we are still going to use IGHV and deletion 17p53 to risk stratify. More often than not, our finances are going to decide what treatment. If it's mutated, we are still going to go for FCR. If they are fit, if they are not fit, then we are going to look at BR, or we're going to go to ibrutinib. I take Pankaj's point that we should keep BTKI for people who can't, a little later, because what to do for people who relapse. BR seems to be doing a good job anyway. We are getting 2, 3, 4, 5 years with it. And as time goes along, we are not going to look at MRD yet. I don't think we are geared up. But we would love to have the novel agents, especially venetoclax. And we look forward to more such molecules coming so that we can become chemo-free, as Sanyal initially mentioned. so that our patients never have to look like patients. They'll be productive in society and going about their normal life. Thank you very much for being very candid on this panel discussion and being very open. Thanks, Pankaj, despite your voice not being great, you joined us. It really means a lot to us. And thank you all panelists. And I thank Caitlin for putting in her clinical thoughts. Thank you very much. Back to you, Avinash.
Thank you.
Thank you. Thank you, Dr. Abhay, for conducting this panel discussion excellently. We enjoyed it. And I must thank you all the panelists, Dr. Sanyal, Dr. Caitlin, Dr. Helen, Dr. Sandeep Shah, Dr. Arshad Raja, Dr. Pankaj Malhotra. And for the speaking, also, I must thank for their lectures, Dr. Sanyal, Dr. Pankaj, and Dr. Helen. So, at the last, let me thank Indian College of Hematology for giving me this opportunity to direct the program. Let me thank AstraZeneca and Thermo Fisher for supporting this event. And let me thank River Root for excellently conducting the event. So we conclude here. Thank you all again. Goodbye.
Thank you. Bye.
Thank you. Thank you. Bye.
Thank you. Bye-bye.
Thank you.